We'll go through it. Okay. So good morning. It is March the 8th. It is International Women's Day. And it is my great privilege and pleasure to introduce Dr. Hutchinson, who is a professor at the university, at McGill University, but comes and has developed an entire program of work and is an icon at McGill and teaches all of the internal medicine, I believe all of the specialties as well, and the medical students about patient-centered care and whole person care. So that is quite a revolution, and it seems a little bit of back to the future when you look at the Canadian Institute of Health Research and the SPORE, the Strategy for Patient-Oriented Research, that's sort of come back. He's a graduate of Ireland and also was a Robert Woods Johnson Scholar at Yale, and has had training with Virginia Satir, who is also a pioneer in, what shall we say, she's a pioneer? Family therapy, and sort of the interrelationship of the way that one models care in professional circumstances based on your personal circumstances, and has incorporated that into the way that you can grow and understand yourself and your interactions better. Anyways, it's very novel to be able to talk about dialyzing people as opposed to patients, and I think that Dr. Hutchinson will give us a wonderful expose and hopefully stimulative conversation. So welcome.
Thank you. So thanks, Adira, and it's great to be here, and I didn't know it was International Women's Day, and maybe it's very appropriate for this presentation, because there is some data that women look at decisions differently than men do. Men tend to be very much focused on the outcome, and women are much more interested at the same time in looking after the relationship. And you'll see that's exactly what I'm going to be talking about. So, dialyzing the whole patient, but probably should be the whole person. Relationships and the relief of suffering, no conflict of interest. This is going to read you a little bit from a book called Heroes, 100 Stories of Living with Kidney Failure. And the story is this guy, Brian Ditty, first story in the book, guy I knew well. He found out that he had kidney disease around the age of 15. He was told his kidneys are shrinking. And he says the following: when I was in grade 11, they told me I should go visit a dialysis unit now because my creatinine was getting too high. My mother made an appointment for me to see the dialysis unit. My mother took me out to lunch for some pizza nearby, and then we visited the unit. We walked into the unit, and all I saw was old people, and they looked terrible. I was thinking to myself, this is what I'm going in for? I left very quickly, and as soon as I got outside, I threw up all over the sidewalk. I guess I was a little more upset than I thought. So I blocked the whole thing out of my mind, graduated from high school, and started college. When I was 18 years old, they transferred me to the hospital, where I kept going in for blood tests once a week. They were monitoring me very closely now. I was 19 when my doctor called me and said it was time to start dialysis. I told him, no, I don't think so. It's not for me. He said, what do you mean? What are you talking about? I told him again, it's not for me. It's not my lifestyle. He then told me if I did not start, I would die in a few weeks. I told him that was fine. I'd had a good life. So what's going on with Brian Ditty? So I think what's going on with Brian Ditty is that he's suffering very severely. He's not in pain. He's not short of breath. He's not nauseated even. But he's suffering very severely. And what I mean by that is suffering in the way that Eric Cassell describes in his book, The Nature of Suffering and the Goals of Medicine. Published a paper in the New England Journal about the 80s, and then this book. And what Eric says is very simple and very important. He says that suffering occurs when there's a threat to your intactness as a person. And I would say our main job in all of healthcare, including nephrology, is how do we treat or diminish or help patients with the suffering caused by illness? I was going to show you a video which won't work, but I'll tell you the story of this slide. It's from a film that we made about end-stage renal disease. And this is a woman, and you can't see all of her, you will see all of her in the next slide, but a woman called Sabrina Kriegs. And we were interviewing patients about, in the film, about what's difficult, what helps, what makes it possible for you. And what Sabrina said basically was, this is a picture of her, and you'll see the whole picture in a moment. At this point, we're talking to Sabrina. She's in her 40s. She's diabetic. She's lost some of her vision, and she's on dialysis for her kidney failure caused by diabetes. In her 20s, she'd been a model. She'd been in California, very good-looking girl, a model. And what she was telling us in the video is, I have a little corner in my house, and I have that photograph of myself as a model. And every time things get really hard, I go and I sit and I look at that photograph, and I tell myself, that's me. That's who I am. So what's Sabrina trying to do? What she's trying to do is hold on to that sense of intactness as a person, which for her is very much connected with being a model, being good looking, and so on and so forth. Okay. So I said our job is to help patients with their suffering. And that all starts, I think, with identifying what's the problem. Because if you think about yourself when you get sick in any way, what you want to know is, what is this? And what does it mean? Every patient who comes to a doctor wants to know that. And what we can do is the following. Separate the patient from the disease. And that of itself is a very powerful way to relieve suffering, because it says, you're still intact. You simply have this problem. Now, if you want to get a sense of how important that is for people, think about diseases that are not fully validated by society. Maybe like chronic fatigue, some kinds of mental illness sometimes, so that's getting better. But what people want with diseases that are not fully kind of validated by society, they would give anything for this to be validated as a real disease. For this reason exactly. Because now it says, it's not me. It's not a problem with me. I simply have something that everybody knows this is a disease. Step one, separate the patient from the disease. But this means that we always have two relationships at the same time to deal with. And each of those relationships can further help the patient deal with the suffering caused by disease. The first is this relationship between the clinician and the disease, and we call that relationship curing, could be called fixing. That's the part of medicine that has to do with dialyzing people for end-stage renal disease, giving them a kidney transplant, giving them medications to control their immune system, giving them antibiotics, so on and so forth. That's most of what we teach in medical school, and it's absolutely essential. Because if I have a problem, and you tell me we can do something to fix that problem, do I want it fixed? Absolutely. However, there's more to medicine than that. The other relationship we have is the clinician to the patient as a person, and we've called that relationship healing. Let's look at those two and see. You see, the point is, they're so different. They require different skills. There's a paradox at the heart of medicine. And we need to kind of encompass that paradox in order to give the best care to our patients. So curing, an action carried out by a healthcare practitioner to eradicate disease or correct a problem from Erica Cell. Healing has been defined as a relational process involving a movement towards an experience of integrity and wholeness, could be intactness, which may be facilitated by a caregiver's interventions, but is dependent on an innate potential within the patient. So two very different things. And one of the problems we have, I think, increasingly, but certainly over the past 50 years, is we pay so much attention to this fixing, curing part of medicine, we sometimes lose track of this other, much older part of medicine, in fact. This is the photograph that Sabrina liked to look at as herself. And I put it again because it shows a perfect example of focusing on fixing things and forgetting about the patient as a person. So here's what happened. I was coming into the dialysis unit at the old Royal Vic, the Ross Pavilion. I see Sabrina there. She's now in a wheelchair, and she's totally beside herself. Like she's just devastated, crying, and she's saying, "Dr. Hutchinson, oh, you can't believe what just happened. I can't believe it. It's just So what happened? So at that point, Sabrina, with her diabetes, had ischemic peripheral vascular disease, and her left leg, I think it was turning gangrenous. Below the knee, it was black, and they were talking about should they do an amputation across her feet or above they weren't sure where. And she was worried about this amputation, and she didn't want to lose any part of herself, as you can imagine, as anybody would. So a doctor came. Apparently, she said he was a dermatologist, and she said he was a good doctor. She wasn't saying he was trying to do anything bad. And so she told him about her worry about her feet and this amputation. And he said, "Sabrina, no problem. I can fix that problem for you this morning." So what he did was he took one of those tin garbage cans and put that at the head of the bed. And then he was at the foot. And then he took Sabrina's toes one by one, pulled them off, and threw them into the garbage can. So every time that a toe came off, she could hear, you can imagine. Now this guy, I'm sure, was not trying to do anything bad. He was trying to actually help Sabrina. He was totally focused on fixing a problem. And he'd lost track of what this could mean to Sabrina as a person. So I think that we absolutely, and most of us won't be that extreme, I understand. Let's hope not. But we need to be very much focused that we have more than one job. And if we focus simply on the fixing part, we may do terrible things to the patient as a person without intending to. I said that these are very different kinds of processes, curing and healing. This is from an excellent book called Getting to Maybe, How the World Has Changed. And they make a great point. They say, look, there's a very big difference between complicated things and complex things. The perfect example of a complicated one is sending a rocket to the moon. You need rigid protocols that are needed. Success depends on a blueprint that directs both the development of separate parts and the specifics and specifies the exact relationship in which to assemble them. Complicated. We increasingly see medicine as a complicated problem, which is why we keep coming up with new blueprints, new algorithms, new ways of doing things that are laid out step by step. Not a bad thing. But we should realize that whole other part of medicine, which is the healing part, is not complicated. It's complex. And the example they give there is raising a child. Rigid protocols have a limited application, and as anybody who has tried to raise a child knows, can be very counterproductive. And you can't separate the parts from the whole. Essence exists in the relationship between different people, different experiences, different moments in time. The other big difference between these two is, with complicated problems, once you've done one, it's easier to do the next one. With complex problems, once you've done one, it may not be that much further ahead in doing the next one, as anybody who's raised more than one child will realize. So very different kinds of things. This is not a new realization. It goes at least as far back as the Greeks. This is a Greek patient. It's a mosaic from the Greek island of Kos, where Hippocrates practiced. This is a Greek patient coming to see a doctor. But he's actually coming to see two doctors. This character here is Hippocrates. And he actually practiced on the outskirts of a temple to the guy in the back called Hippocrates, called Asclepius. So Hippocrates represented the fixing, curing part of medicine. He and his colleagues tried to fix and cure whatever could be fixed and cured in patients going to and from the temple. Asclepius is the Greek god of healing. So we don't know all of what happened, but the Greek patient would go to the temple, sleep in the temple, have a dream, and something to do with that was meant to start the healing process. Two very different kinds of activities. So we've used this kind of Greek division, and the Greeks were great at dividing things, logos and mythos, so on and so forth. And we've used a Greek symbol to represent the combination of these two things, which is whole person care. The white snake represents the curing, fixing part of medicine. This is the caduceus. The black snake represents the healing part of medicine. You can see they're very different. They're connected. And we may come back to, well, what does this staff represent? But not for now. First of all, I want to just contrast what does it take to do a good job of fixing, and what does it take to do a good job of healing, and look at how different those two are. Let's start with the curing part. So why do patients come to hospital, to a doctor, to a healthcare situation? They want to be cured, no question. When I go to see my doctor, I want him to fix what can be fixed. That's exactly what you'd expect. I don't want any character telling me, you need to heal here, Tom. I need this problem fixed. Why? Because I want to hold on to everything I've got. I am not interested in growth or development when I go and see my doctor. So, for instance, if I'm a tennis player and my knee is bothering me, and I go to my doctor, what do I want? I want that knee fixed. I do not want him to tell me, Tom, you have to come to grow to a new sense of yourself. You don't need to play tennis. Bullshit. So, very clear. I want to hold on. Another way of putting it is, I want to survive. But not just survive physically, which I do want, but survive in all of the ways that I see as myself. This is part of that sense of intactness as a person, right? If I see myself as a tennis player, I want to continue to be a tennis player, and whatever else it is that goes with my life. And how do I see myself? I definitely see myself at the effect of this disease. Here I am, and something has attacked me, and I'm looking for help with how do we deal with this thing that's attacking me? So for the doctor or other healthcare worker, we're going to look at communication. So what do I communicate if I'm trying to cure a problem? I communicate content. Content means I tell you, no, Tom, this problem with your knee, it may be a meniscus, we're going to do this, we're going to do that, maybe you should take some Advil, all of that. Oh, that's all content. How do you communicate content? By digital means. What does that mean? It means that every word I say has a meaning. You could look it up in a dictionary. In fact, I could communicate digitally this as effectively by giving you something printed or sending you something on your iPhone, sending you an email message that would be equally effective in giving you the information about the content that I need to do. This kind of communication is conscious. I know what I'm doing. I know the topic, and I know what I'm doing. If you ask doctors, are they good communicators? What do they say? They are. They always say they are. And this is what they mean. They mean, I know the stuff, I know how to express it, and I'm perfectly conscious of what I'm doing. All good. And I'm hoping you're now beginning to think, well, what else is there exactly? And we'll come to that, because that's the other side of this whole table. And the kind of presence you need here is to be a competent technician. And we all want to be competent technicians. And I want my doctor to be a competent technician. If I'm being dialyzed, I want him to know about dialysis. I want to know what should happen. If I'm being treated for my transplant, I want him to know the latest in what kind of medications we should be using, how we should be monitoring, so on and so forth. No question. So all of this is good and absolutely essential. The message is there's more to medicine than that as well. Let's look at the other side. The healing side. What is healing? Yeah, here. So this is a nice diagram from Balfour Mountain, Michael Kearney. They basically say we all go somewhere between wholeness, integrity, and homeostasis and inner peace. Total pain, suffering, and anguish. Moving in this direction is wounding. Moving in this direction is healing. Now, most people like this diagram. You know why? Because they think to themselves, look, if I ever got here, I sure want to get back to here as quickly as possible. The bad news, ladies and gentlemen, is if anything significant happens, you realize there is no way back. There's no back to where you were. Because there's an element of time in healing which is left out of this diagram. So what it looks like is this. It's a healing journey. Healing going in this direction, wounding going in this direction, time in this direction. And here's a graph I'm going to show you of a woman healing from an abusive relationship. Another connection to Women's Day, I guess. I hadn't thought about that. And here she is. So, at this point here, she's in the relationship. Here, before she's thought about doing anything about it, her subjective quality of life is very, very low. Total pain, suffering, and anguish is down this side. She's pretty much there. What happens then is she decides to leave the relationship, and this is the point at which she leaves. What do you notice? Just after she's left the relationship, her quality of life is better than it's been for a long time. And what happens next? It plummets. And it takes her almost a year to get back to a quality of life not quite what it was at that moment she left. Why? Why is the same kind of why that you've seen all the time in your patients. I say it's most clear maybe in palliative care. So I'm thinking about palliative care. I know I'm dying. I know I probably shouldn't have any more chemo. I'm struggling with it. And at some point I decide, okay, I think I really need to see palliative care, or I need to go to palliative care. Probably feeling pretty good about that decision. Things have clarified. What happens next is I have to face the realities of my new decision, as she had to face the realities of her new life. And my self-esteem and my sense of wellness can plummet again. So healing is a journey, and it's a roller coaster. It's not simply a one-directional improvement. It goes up and down. And that's very important for our work as physicians, for the following reason. What people now need to do, instead of holding on, we need a little bit to learn how to let go or to fall. And with any serious challenge, that's part of it. The payback is not survival. It may be survival, but it's growth. Because you really have to grow into a new sense of yourself. And you begin to see yourself as responsible for coping with illness. What you can see here is this is an internal response to suffering. Something happens, I'm challenged, my sense of intactness as a person is really threatened, I'm feeling challenged. And now I need to change in some way to almost a new person in a certain way. That's the healing response to suffering. We need two responses to suffering. We need the fix-it-cure-it part to the extent that that will work, and we need that healing growth response. If you think of any of your patients on dialysis, patient with a transplant, patient with chronic kidney disease, they have to be doing both at the same time. It's never as simple as let's fix this problem. There's always a huge change to which they now have to adjust and grow into in order for that suffering to improve. What's your job as a doctor or healthcare worker? First of all, what are you trying to communicate on this side of the table? What I would say you're trying to communicate is relationship. Why is that important? Well, because if the main threat to me is my sense of myself as a person, where I get my sense of myself supported is from other people. So what I need from you as my doctor is a message somehow that you're there for me and that I still count as a full person, whatever is happening to me. That makes sense? How do you communicate relationship? By what we're calling analog means. Not digital, but analog. What does that mean? Here's a great, I think, summary from a book called The Pragmatics of Human Communication. What then is analogic communication? The answer is relatively simple. It's virtually all nonverbal communication. This term, however, is deceptive because it is often restricted to body movement only, to the behavior known as kinesics. We hold that the term must comprise posture, gesture, facial expression, voice inflection, the sequence, rhythm, and cadence of the words themselves, and any other nonverbal manifestation of which the organism is capable, as well as the communicational clues unfailingly present in any context in which an interaction takes place. Here's the question. Do you think your patients watch your analog communication like a hawk? Absolutely. Much more than you, unless you really focus on it, than you can fully realize. If you've been sick, you know that, because you waited a long time for the doctor or the nurse to come, almost always. When they come, it's like watching and it's not just what they tell you, it's everything. Do they seem in a rush? Do they sit down? Do they seem that they're impatient? Do they seem interested? In order to give myself, which was very incomplete, but a sense of, well, what might it be like to sit in a dialysis unit for 4 hours and be dialyzed? I said to my friend Paul Barry, Paul, you'll put in a femoral catheter and will dialyze me for 4 hours. And I'll have a real sense of what it's like. And he said, Tom, we're not doing that. We're not doing that. And so eventually all I did, which was pretty pathetic, but it had some effect, was I sat in the unit with an arm kind of down for 4 hours and just waited and seen. And there's no question. I noticed everybody who came into that room. The nurse came, what's she doing? Does she seem rushed? The doctor. So all of our analog communications watch like a hawk, and people interpret that as their relationship to us. Here's a great study, I think, from Wendy Levinson et al., looking at how powerful that is. So what they did was they took surgeons who'd been sued twice or more, and surgeons who'd never been sued. They recorded interviews between the surgeons and their patients. They took 10-second segments of the interviews. They changed the frequency so you couldn't hear what the surgeons were saying. And they had blind observers score the 10-minute segments on different aspects of communication. Like the tone, was it warm, professional, concern and anxiety, and so on. And what they found was that if you had a dominant tone of voice being conveyed in deep, loud, moderately fast, unaccented, and clearly articulated speech, the kind of speech that's perfect on that curing side to get a point across, you were approximately 3 times as likely to be in the soothe group as a non-soothe group. So how did they interpret this? So they interpreted this. They said, oh my God, we got to start training surgeons on their tone of voice. And I think that is absolutely the wrong way to go. Because we will make people so neurotic about their tone of voice, their body language. That is not the answer, I do not think. We cannot fiddle around with this stuff because it's mostly unconscious. And it's probably mostly going to stay unconscious. And we all have different styles. And that's just fine. Because our patients not only watch us like a hawk, they're also extremely forgiving, I think. And they know that Dear 11th is like this, and Tom Hutchinson's like this, and so on and so forth. And they make adjustments. But they are able to read how we're actually relating to them or not. And so what we're trying to teach medical students is not get neurotic about how you sit, how you talk, your tone of voice. Don't try and change any of that. But do give some thought, and some, not just thought. See if you can become more aware of how am I actually relating to this person. And we've used the work, Adira mentioned it, we've used the work of Virginia Satir to teach something which is in principle fairly simple, although not necessarily always so easy to do. And the principle is the following. We're saying we want our students to be congruent. What does that mean? Well, Virginia, whom I met 1,000 years ago, she's now dead, but a fantastic workshop that I went to, and she taught all kinds of things. But this was one very simple thing. What she said was, when you interact with another person, there's yourself, there's the other person, and there's the context. And the aim is, if you're congruent, can I stay in touch with myself as a person? What am I feeling here? What am I thinking here? Can I stay in touch to the extent that I can with the other person as a person? Put out myself in their shoes to the extent that I can, and also stay in my own shoes. And very much be aware of the context. So a medical context, completely different than a social context. Should not lose track of that. What she said was, and she said she found this out from a time when she was at home. She had a big family, her siblings, and she developed a problem with her hearing, apparently when she was about 8. And what she noticed was people were communicating to each other in how they acted and behaved in ways that she hadn't noticed before when she had her hearing, which she then got back. And she said, basically, when we're under stress, there are 4 main ways that we adopt what she called a survival stance, but also a communication stance. And they're the following. The first is placating. Placating, I forget about myself as a person. A lot of people with a lot of goodwill, medical students, nurses, so on and so forth, have bought the point, which is an important point, medicine is for the patient, to the extent that it's for the patient 100% and I don't count. There's a problem with that. 2 problems. One is, it's not really what patients want. They want a sense of you as a person, and they're willing to make space for that. But also, if you try and do this long term, very difficult to do. Because what you need to do that is to suppress yourself. And if you suppress yourself long term, you get pretty angry internally. Not a long-term solution. And sometimes we go from this stance, because we've suppressed those emotions, to the opposite stance, which you also see in medicine, the blaming stance, which is, I'm the one who knows. It's my expectations have to be met. You need to comply with what I'm saying. You're a non-compliant patient. You're a dysfunctional family. You have a personality disorder, whatever it is. All of those things can be true. But we can use medical terminology also to put the blame on the patient, the blaming stance. You can imagine neither of these works well. Placating stance probably works a little better than the blaming stance, depending on the person. But somewhere we've decided in medicine, we're going to get rid of emotions from the whole process. That'll solve a lot of problems. That's what we think. And so we think, let's get rid of ourselves as a person. Let's get rid of the patient as a person. We'll simply become a problem solver in the so-called super reasonable stance, or sometimes called computer brain. You ever seen that in medicine? Most of us have. I mean, that's the kind of thing where you're in the ICU and you're going around with some fellows, patient is sitting there perfectly awake but perhaps intubated, and you're talking about them like they don't exist. Just kind of, what do we do next, and should we do this and give this, as if they're not there as a person. And really, I'm not acknowledging myself as a person. It's all just a problem to be solved. Just be clear, although this is meant to solve a problem, nothing will drive people as crazy. If you have a serious emotional problem that's worrying you, for you to be dealt with in this kind of super reasonable way. Finally, of course, what else can you lose? Everything. The so-called distracting stance, where you lose touch with yourself, the other person, and the context. Do we do that in medicine? We do. I'd say the popular way to do that now is multitasking. You have friends who are so multitasking that they're not kind of on the planet. They're so, you'd like to tie them down because they're kind of never quite there. We have reports from medical students, and I don't think it's rare, of doctors going into a room and making a joke that's completely inappropriate. That's the distracting stance. Alcohol, drugs, so on, can also get you into this stance. This stance almost never works in clinical medicine. It doesn't mean that you can never joke with a patient, because I've seen patients, even in palliative care, dying, sitting around with the family, and people are laughing. Not quite the same thing. This is where you go in and do something completely inappropriate. Okay, so what we would say is, and we do various exercises to try and train our students in what do these stances feel like, how do you become aware of a stance, what do you do about it. What we would like, ideally, is as far as possible, we're congruent, aware of ourselves, aware of the other person, aware of the context. Susie, is Susie here? No. Yeah, there you are, Susie. Asked a very good question last night. We had a little discussion, and she said, what about how do we deal with people who are dealing with overwhelming kinds of problems? Isn't that a great burden for us? How do we go away from that unharmed in a certain way? And that's the problem of compassion fatigue. And my answer to that would be, there isn't just a circle and divisions here. There's also these lines. And these lines represent boundaries. And so I think the answer to compassion fatigue is not preventing yourself feeling when you're in those situations, but remaining clear that, at least for now, this is not me. This is another person that I'm putting myself in their shoes. And I'm still here. Because if you can do that successfully, something people have called it exquisite empathy, but if you can do that successfully, you can deal with extremely overwhelming situations and still come away not depleted, but even possibly energized. Okay. I want to come back to the diagram again. I've stressed the fact that these are very different. What you need on each side of this table is very different. I also want to stress the fact that you absolutely need both and that they synergize with each other. So, for instance, If I have a doctor who knows the content, I'm much more interested in having a relationship with him. If I have a good relationship with him or her, I'm much more ready to listen to the content he or she is trying to communicate, and so on up and down the line, right? So we need both. They're very different, and they synergize. What did that stake represent between the two snakes? I think that represents you as a physician or as a nurse, being able to hold those two things in tension. Not going completely one way, not going completely the other way, staying aware enough. I want to say one other thing. Sometimes in very difficult situations, and Priya, you raised this last night, and I was thinking about it subsequently. You're in a very difficult situation, you're trying to communicate with somebody, and you think to yourself, I don't know what words to say. Maybe realize the words you say are probably not so crucial. That's much more on this digital side. What's much more important is, am I really caring? Am I really respecting this person? And am I willing simply to wait until what emerges, emerges? So often the answer is don't say too much, because you may say things that you don't mean out of anxiety. You may need to wait and see. And my experience is if you can do that, surprising things do emerge as the way to go forward. Okay. Pretty good for time, I think. My summary slide is the following. Relieving suffering, I think, is the primary goal of all treatment for kidney failure and kidney disease. This requires both fixing or curing, whatever can be fixed or cured, and developing a healing relationship with the patient. These two processes potentiate, but they also enhance each other. Curing requires technical knowledge and expertise. Healing requires a special quality of presence. A nephrologist, or any good doctor, nurse, healthcare worker, is one who embodies both in the care of patients. That's not just good for our patients. That's also very good for us. Because the other thing for me is the problem of burnout is we're too preoccupied with all of the mechanics and not present enough to the benefits of relating to people as people. Because that's where the real juice, the real energy comes from in medicine. And if we lose that, we're at much greater risk of burning out. Just to say, if you want to read more about this, we have published 2 books about it, both by Springer, both available on Amazon, one a multi-author book, the other a single-author book. So I'm ready and open for questions.
So can I start? There seems to me a paradox in our new obsession with communicating everything with electronic health records and spending a lot of time documenting things electronically at the same time as we're trying to develop relationships. And so do you see a solution, or how should we address this? Because I see that becomes harder and harder, where the world is about efficiency and effectiveness and standardizing.
Yeah.
And yet there's this whole other part of medicine that most of us signed up for. So
it's a great question. I had a medical student come up to me after a lecture last week and say, Dr. Hutchinson, are things improving or are they getting worse? And my answer to that is I think they're doing both at the same time. No, seriously, I do think that the electronic medical record, and I don't know what you do exactly with it, which was believed to be such a wonderful kind of thing, and it has advantages because information can pass rapidly and you can see everything. It also creates a huge problem in terms of so much to be documented in a kind of categorical way, tick this box, that takes us completely away from our relationship with the patient. Many patients complain now that their doctor is not looking at them, they're looking at the screen. So it's a huge problem which we haven't solved. I do think there's a counter movement, not against digital records exactly, but for how do we, within that context, make time to really listen to people, because that's what people want. So, yeah, it's a huge issue. I think the other part which I didn't mention is, because curing and fixing is a complicated problem, it's perfectly reasonable to think about standardizing that. At the same time, we all know practically no standard algorithm works in any individual patient. It has to be personalized. But what's even more powerful is my relationship to a person cannot be standardized. I'm going to do it differently than you will and everybody else will, and for every different patient. And if I'm not aware enough and alive enough to that, I'm really going to have a hard time with that whole healing relationship. So what we're trying to teach medical students is not just this Virginia Satir stuff, but teaching them how do you stay self-aware, even in very stressful situations. So it's a huge challenge. I don't have the answer, but I totally agree. It's a huge challenge.
David?
Yeah.
Hi, thanks very much. In our environment in Vancouver, especially, in nephrology here, we deal with an awful, a dramatic variability in ethnic diversity in terms of where people are coming from, but also just in terms of their ability to communicate with us and our ability to communicate with them in English, because that's the only language I speak. And we deal a lot with translators. And I am extremely challenged when being with a patient whose ethnic background I don't totally relate to, but I just don't understand the complexities of it. I have a translator in front of me who's very good at the mechanics, and I spend my whole time, having this conversation with the translator and being very good at the mechanical part of it, but not being able to establish that relationship with the patient. Can you give me some advice on how to do that better?
So first of all, to acknowledge the problem, and we've all had that problem. My experience of that is we had quite a lot of Inuit patients coming from to McGill, and my experience would be, I would say to the translator, can you ask her, when did the pain start? And so then the translator would ask the question, the patient would talk for about 10 or 15 minutes, and then the translator would say, yesterday. And I'd say, well, what was she saying for 10 or 15? And he'd say, no, just yesterday. So it's a big problem. And I don't think it's a completely bridgeable problem. I do think it's important to realize that below all of that cultural difference and even language difference, there is that analog communication that's happening. Am I taking time? Do I seem interested? Do I seem rushed? Can I, as far as I can, try and put myself in those shoes? And I think that's the best you can do. And that's probably more effective than you think. That's all I could say. But there's nevertheless a huge challenge. Yeah.
Great. Diamond or Nanaimo, any questions there? Yes or no? Okay.
You probably know that our hemodialysis population is very elderly, like more patients are greater than 70 years of age that are coming to dialysis. And I find that their understanding of their disease process is not completely there. They might have some cognitive impairment. And from what you're saying,
a little louder? I'm having
we're getting an older population to our hemodialysis population. And I don't believe that they completely understand their disease process, and they might have cognitive impairment. And so what you said about healing is that you have to look at the potential of the patient if they can heal. Is it possible? Or I don't know, I just find that difficult with this population.
So a few things I would say. First of all, the advantage of old patients is that they've learned a lot of healing in their life. They've had a lot of challenges, and they've gotten through a lot of things. So there's more resources there than you might first think. Secondly, it's true, they may not understand all of the details of their kidney disease and what's being done for it. And maybe they don't even want to know. and that's okay. But the third thing is, I think that one of the last things to go in dementia and cognitive impairment is emotional connection. People still sense whether you're on their side, whether you care, whether you take time. And that can be hard to realize because you know that they're not quite taking in everything. So I think this, like everything else, what does this require to do healing and curing at the same time? I think it needs self-awareness, but also continually reminding yourself, there's more here than I think. There's more potential here than I think, and can I just be open to that? I don't have to force myself to believe something that's not true, but can I be open to that? And I think if you can, it will work better than you might expect, at least. Because I don't think it's necessary to understand a lot of complicated cognitive stuff in order, in essence, to heal. Does that make sense? It's a challenge, though. It's not easy. Yes. Yeah.
Thank you for that. That really nice talk. Your circle is patient and doctor, but maybe you've intentionally left out the bigger circle, which is the hospital environment, people coming in to draw blood while you're having a conversation with the patient next to you screaming. So, I mean, you probably don't have any answer for that because that's more of a systemic issue. But I guess you have to have growing awareness of within the institution of how to create atmosphere or how to have a permissive environment for those conversations and that relationship to develop, and a support network for those physicians when they are having trouble.
Absolutely. What you're saying is absolutely true. And you could put that all in the context, mm-hmm. But it's a complex context, yes. For sure. It's not a simple context. So much going on, so much distraction, hard to find spaces within that to have these kind of relationships. But I do think that's something we need to focus on. And I think you're probably trying to do that at St. Paul's, but that's very, very important. The other part to say is sometimes, and I thought maybe that's what you want to say, and maybe partly it looks like I'm just saying, oh, there's the doctor and the patient and the context. But I understand there are lots of people involved in this, and it is a team. The only thing I would say is, in that way, each member of the team needs to bring these two aspects to it. It's like a hologram that so you can't. What I'm trying to say is, doctors can't say, well, we're not going to worry about that relationship part. Let the nurses deal with that. That is never going to work. Each person in the team needs to bring their part of it on both sides. And then I think it can work. But absolutely, we're working in teams. Yeah. And I think part of what we're talking about here is intimacy of a certain kind. And we have to start to create healthcare institutions that are open or favorable to intimate interactions. So my hope for you is when they build a new St. Paul's Hospital, they'll build it with that in mind, not just with efficiency and technology in mind, but spaces for intimate interactions, because that's key to healthcare.
Actually, the plan is, I think, to have individual rooms for starters, so at least there's privacy, which we don't have everywhere right now. So, no, thank you for a really inspiring Friday morning talk, and I think that we'll take this into not just our work lives, but our other lives as well. So thank you very much.
Thanks very much. Thank you.